Welcome to the Deep Dive, your shortcut for understanding the material that really matters. Today, we're jumping into Chapter 16 of the nursing text, really tackling the complex world of trauma, stressor-related, and dissociative disorders.
Yeah, our goal today is to cut through all the clinical jargon and give you those core insights. We're looking at the whole path, from early childhood issues right through to how trauma shows up in adults. We'll cover the biology and maybe most importantly, what this actually means for nurses, for providing compassionate care.
And right off the bat, the textbook makes a really important point about what trauma is. We often think big scale, right? Combat, disasters.
And those are included, of course.
But the book emphasizes that so much damage, maybe the most pervasive damage, comes from really common interpersonal stuff. Things like abuse, sexual or physical, or severe neglect, abandonment, even sudden loss.
Exactly. And that understanding, that shift, is the whole basis for what we call trauma-informed care, or TTAC. It's basically a framework. It means everyone in healthcare needs to recognize trauma's affects all kinds of trauma in all settings. The aim is to stop causing more harm and, well, reduce the damage that's already there.
Okay, and for you listening, the text lays out some core things nurses need, like developing your own resilience, really understanding adverse childhood experiences, ACEs getting the neurobiology down, and being an ethical advocate for your patients. That's kind of our map for today.
Sounds good. We'll start with the earliest impacts, those attachment issues that stem from really inadequate early care. Then we'll move into PTSD, first in kids, then adults. And finally, we'll spend some solid time on those really complex conditions, the dissociative disorders.
All right, let's unpack those early problems, attachment disorders in kids. The book ties these directly to what it calls a grossly inadequate nurturing environment. Basically, a failure in bonding with the caregiver, especially before the child is about 8 months old. That critical window.
And this lack of nurture shows up in two main ways. They're almost opposites, really. First, there's reactive attachment disorder, RAD. This child is emotionally withdrawn, inhibited. When they're upset, they almost never seek comfort. And crucially, they don't really respond when comfort is offered. It's like they've learned there's no point in reaching out.
Okay, withdrawn. And the other side.
That's Disinhibited Social Engagement Disorder, or DSED. These kids seem to have no normal fear of strangers. They're overly friendly with everyone, almost indiscriminately. They might be really eager to go off with people they don't even know.
Wow, that sounds dangerous.
It is. It's not genuine warmth. It's a failure to develop that basic understanding of who's safe and who isn't. The text mentions the Tizard study from '77. It showed this really clearly in kids raised in institutions without one consistent caregiver. Some became withdrawn, like in RAD, others overly social, like DSED.
And the timing, that early window, is key because of the brain development, right?
Exactly. The infant brain's right hemisphere, which handles a lot of the social and emotional stuff, attachment included, is incredibly vulnerable then. If there isn't that reliable, nurturing person to connect with, well, the brain struggles to build those foundational pathways.
So the treatment has to involve the caregivers, too.
Absolutely. It has to be about strengthening that relationship within a safe, stable context. Individual therapy, family therapy, whatever it takes.
Okay. Let's shift now to PTSD, Posttraumatic Stress Disorder, in children and adolescents. The numbers mentioned are pretty sobering.
They really are. Lifetime prevalence in adolescents is around 5%. But for certain specific severe traumas, like witnessing a parent being murdered or experiencing sexual abuse, the risk of developing PTSD shoots up dramatically, sometimes close to 77%, even 100%.
And how does it look in really young kids, preschoolers?
It's different than in adults. You might see play becoming really restricted, or maybe it obsessively includes parts of the trauma. They might withdraw socially, show self-destructive behaviors, and lots of negative emotions, shame, guilt, anger. Plus, there's high comorbidity, learning problems, depression, later substance abuse. It can create this awful cycle of re-victimization.
Let's get into the biology here. The text talks about the HPA axis. Walk us through how chronic stress messes that up.
Right, the hypothalamic-Pituitary-Adrenal axis. Think of it as the body's emergency stress response system. In chronic trauma, this system gets overworked. The hypothalamus keeps sending the signal, the pituitary keeps telling the adrenals, and the adrenals just keep pumping out stress hormones like cortisol. This constant flood of stress hormones actually changes how genes get expressed while the brain is still developing. The alarm system is basically stuck in the on position.
Okay, that explains the long-term changes, but what about the cycling? That switch between being super anxious and then totally shut down? The book brings in the Polyvagal Theory here.
Yes, Porges's polyvagal theory is really helpful for understanding this complexity. It suggests our autonomic nervous system, specifically the vagus nerve, has sort of three response modes in a hierarchy. The most evolved, the highest level, is the ventral vagal system. That's our social engagement mode. Feeling calm, connected, safe. This state actually inhibits the fight or flight response.
But if that doesn't work, if you don't feel safe,
Then we drop down a level to the sympathetic nervous system activation. That's the classic fight or flight response. Heart racing, muscles tense, ready for action, hyper aroused.
okay,
But if that doesn't work either or isn't possible, the system can default to the oldest pathway, the dorsal vagal state. This is a shutdown response.
like an animal playing dead.
Exactly like that. It's profound immobilization. Heart rate slows way down, breathing gets shallow. You feel hyper-aroused, numb, maybe depressed, disconnected. And that switching back and forth between the hyper-aroused fight or flight state and this hyper-aroused shutdown state, that's really characteristic of complex PTSD.
Which brings us to the window of tolerance.
Right. That's the sweet spot, the optimal zone of arousal where we can function well, think clearly, feel connected. Kids and adults with trauma histories often have a very narrow window of tolerance. They're easily pushed into either hyper or hyperarousal.
So we're doing a nursing assessment.
We absolutely need to look for signs of this cycling. We use interviews, observations, specific screening tools. The text mentions things like the child dissociative checklist or using something like the Denver Second Developmental Screening Test to see if the child's development is actually on track for their age, because trauma can really derail that.
And common nursing diagnoses would be things like post-trauma response, impaired attachment.
Exactly. Post-trauma response, impaired caregiver-child attachment, maybe impaired adolescent development, depending on the age. And the treatment follows a clear model, the stage treatment protocol.
Okay, what are the stages?
It makes sense, really. Stage 1 is all about safety and stabilization. You have to establish safety first, create predictability, help stop any dangerous behaviors. You can't process trauma if you don't feel safe.
Makes sense. Safety first.
Then, stage 2 is about reducing arousal and regulating emotion. This is where you start working on managing the symptoms, maybe doing some careful memory work, reducing dissociation.
And stage 3?
Stage 3 is developmental skills catch-up. Trauma often interrupts normal development, so this stage focuses on building skills, problem solving, social skills, things like that, integration.
And throughout all this, the book really emphasizes connection, right?
Absolutely. Connection and relationship are named as the most important ingredients for healing. Trauma disconnects, healing reconnects. Oh, and there's a small but interesting point about imaginary friends. If a child uses one for coping, the nurse shouldn't dismiss it. Instead, gently explain that this friend is actually a really special part of themselves that their brain created to help them cope when things felt too big or scary.
That's a really sensitive approach. What about specific therapies?
The text highlights the evidence-based ones. Cognitive behavioral therapy, CBT, is one, and eye movement desensitization and reprocessing, or EMDR.
EMDR. I've heard of that. Is the idea sort of using the eye movements or tapping to help the brain process and file away traumatic memories that are stuck, like moving them from the emergency now file to the past history file?
That's a great way to put it. The dual attention stimulus, the eye movements or sounds or taps, seems to help the brain process the distressing memory without getting completely overwhelmed by it. It facilitates integration.
Okay, let's shift to adults now. PTSD symptoms sound similar. The re-experiencing, avoidance, hyperarousal, mood changes.
They are largely similar, but it's worth noting that the trigger isn't always something dramatic like combat. It could be finding out you have a life-threatening illness, for example. The core issue remains that physiological reaction, the terror, the tension. It makes the past feel intensely present. And because of the link with adverse childhood experiences, ACEs, comorbidities are really common. Substance use, depression, anxiety, sleep problems are often part of the picture.
The chapter also mentions two related conditions, kind of trauma light almost, adjustment disorder and acute stress disorder.
Right. Adjustment disorder is considered milder. It's triggered by stressors that aren't necessarily life-threatening, maybe retirement, a relationship ending, dealing with chronic illness. Symptoms show up within about 3 months.
And acute stress disorder, ASD.
Acute stress disorder, ASD, is basically PTSD symptoms, but in a shorter time frame. You need a certain number of symptoms like numbing, feeling detached, sleep issues, irritability. But the key difference is timing. ASD symptoms occur between 3 days and 1 month after the trauma. If they last longer than a month, the diagnosis typically shifts to PTSD.
Got it. So for adult interventions, what's key for nurses?
Education is huge. Helping the person understand their reaction is a normal response to an abnormal event. That can be incredibly validating. We also teach self-regulation skills, deep breathing, mindfulness, imagery, and gently guiding them to develop a narrative of what happened, maybe exploring feelings of responsibility, is important therapeutic work.
And medications.
Pharmacotherapy can help manage symptoms, but it's usually secondary to therapy. The SSRIs, sertraline and paroxetine, are FDA approved for PTSD, but therapy like exposure therapy, cognitive restructuring, EMDR is really the primary treatment.
Okay, final section and maybe the most complex. Dissociative disorders. Let's start with dissociation itself. What is it, fundamentally?
So dissociation is an unconscious defense mechanism. We all dissociate mildly sometimes, right? Like highway hypnosis when driving.
Oh, yeah, zoning out.
Right. But pathological dissociation is different. It's a severe disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. It's the brain's way of coping with overwhelming, unbearable trauma by basically breaking the experience apart.
Yeah.
Fragmenting it so the person doesn't have to consciously experience the full horror.
Okay, and the specific disorders.
The first is dissociative amnesia. This is an inability to recall important personal information, usually something traumatic or stressful that's too extensive to be explained by ordinary forgetfulness. A subtype of this is dissociative fugue. That's where someone suddenly travels away from home, can't recall their past, and might even assume a new identity.
Wow. Okay, what's next?
Depersonalization, Derealization Disorder. This involves persistent or recurrent episodes of one or both. Depersonalization is that bizarre feeling of being detached from yourself, like you're an outside observer of your own thoughts, feelings, or body. Really unsettling. Derealization is similar, but focused outward. Your surroundings feel unreal, distant, foggy, dreamlike.
Like watching your life on a screen, maybe?
That's a common description, yes.
Yeah.
Very detached. And then there's the most widely known dissociative identity disorder, or DID.
Formerly multiple personality disorder.
Correct. DD is characterized by the presence of two or more distinct personality states, often called alters. These alters recurrently take control of the person's behavior. They can have different names, ages, genders, traits, even different voices or mannerisms. The original or host personality often experiences periods of lost time and is usually very confused by evidence of the alter's activities. And it's critical to know the suicide risk with DD is incredibly high. The text cites up to 70% of outpatients having made attempts.
That's staggering. So for nursing care with DDD, where do you even begin?
Safety first, always. Phase 1 of treatment is stabilization, establishing safety and trust. And a really key intervention mentioned in the text, especially for managing dissociation itself, is teaching grounding techniques.
Grounding, what does that involve?
Because dissociation pulls the person away from the present moment, grounding techniques are all about bringing their awareness back to the here and now, using their senses. Simple things like feeling their feet firmly on the floor, maybe stomping them lightly, holding onto a piece of ice, noticing the texture of the chair fabric, describing objects in the room. It helps anchor them back in their body, in present reality, countering that dissociative detachment.
Okay, that makes a lot of sense. As we wrap up, what's the big takeaway from this chapter?
I think maybe two main things. First, the profound impact of early trauma. It literally changes the developing brain. We have to understand that. And second, that phase-based approach to treatment. Stabilize first, then carefully process the trauma, then work on integration and reclaiming developmental skills.
And that fundamental shift in perspective you mentioned earlier, moving from asking, what's wrong with this person?
But asking what happened to this person, that changes everything. It fosters compassion and leads to much more effective care.
It recognizes that these aren't character flaws, they're survival adaptations.
Exactly. The body and mind did what they had to do to survive. Treatment is about helping them find new ways to live, ways that involve connection and integration rather than fragmentation, recognizing, as the saying goes, that the body keeps the score.
So a final thought for our listeners.
Yeah.
Maybe think about resilience.
Yes, despite everything we've discussed, people do possess an incredible capacity for resilience, the ability to maintain or regain mental health despite adversity. As nurses, we can actively look for and build on those strengths, use strength-based approaches, foster that inherent resilience in every interaction.
Fantastic. Thank you so much for walking us through this really dense but vital chapter. And thank you all for joining us on the Deep Dive.